Hello everyone, how are you all? So welcome again to First Aid AMC MCQ free 2-week session. Tonight we are going to finish cardiology theory sessions. Okay, so we did cardiology first class and we mainly focused on chest pain and especially on myocardial infarction, right? So do you guys have any questions in our previous class? Okay, that's all good. So let's start our session tonight. Tonight we will do mainly heart failure, valvular heart disease, and also we'll cover hypertension. These three are very important topic for your AMC MCQ as well. But obviously the most important topic from cardiology will be always myocardial infarction. And it's very, very important. I can't say enough how much important it is. It comes in the ECG, it comes as questions, and a lot of things actually comes from there. But I hope the discussion that we have done, it should cover everything. Before we start, we will start with an animation of congestive cardiac failure. It means what is heart failure, right? So let's start having a look at this video first.
A healthy heart.
Okay, so this is just a short video on congestive cardiac failure, right? So there is a lot to understand from this point because it's important, and the pathophysiology is all that you need to understand this topic. I got a question from Dr. Mohana. So I have a question on the 48-year-old women for which answer was troponin. Should it not be exercise stress test? If the patient is comfortable now, is troponin indicated? Now, the thing is, like, in a real scenario, even if the patient is comfortable, like we usually will do a troponin test because that's an indication, at least someone who is having chest pain, before sending for exercise tolerance test, we should send them for a troponin. Okay, so first make sure, and then you send it for an exercise tolerance test. What is the problem happening with hearing, Dr. Nisha? I think that everyone is able to hear properly. Okay, so let's start with congestive cardiac failure. So this is a scenario: a 60-year-old man presents to his primary care physician for several months of dyspnea on exertion. That means there is shortness of breath on exercise, on exertion, and there is lower extremity swelling. He has a past medical history of sarcoidosis. On physical exam, JVP is distended. There is pitting edema in the lower extremities. And you did an echocardiogram, which shows ejection fraction of 35%. A normal person's ejection fraction should be more than 45 at least. So ejection fraction, it can show that what is the degree or severity of a heart failure. Okay. Now, this patient is having heart failure. Any patient who is this age group having shortness of breath and body swelling, like a pedal edema, we should consider congestive cardiac failure in our first possible diagnosis. So have a look on these two cases first, because it's important and you have to find out what's the difference between these two. And the thing is, both of them are having a heart failure, but their presentation is little different. So you've got a 62-year-old man with hypertension, dyslipidemia, presenting with dyspnea and lower extremity edema for 2 months. On exam, there is raised JVP, an S3 gallop rhythm, and apical impulse is displaced. Chest X-ray shows enlarged cardiac silhouette And the echo shows dilated left ventricle with an ejection fraction of 35%. That means it's below 45. So this patient ejection fraction is low. Patient having features of congestion, which is JVP is distended. Patient having lower extremity edema. So that's all congestion, as you can see. Look at the next one. A 57-year-old man with history of multiple myeloma presents with dyspnea and lower extremity edema for 2 months. There is JVP distension, S4 audible, apical impulse is non-displaced, chest X-ray shows normal cardiac silhouette, and echo shows thickened left ventricle with an ejection fraction of 65%. So in here, you can see ejection fraction is more than normal in here. So that's the difference. In one case, you can see that left ventricle is dilated and ejection fraction is low. In another heart failure, ejection fraction is more than normal with a thickened left ventricle. But there is congestion, like raised JVP is there, pedal edema is there, everything is there. So what is these two things? So we need to find that out. Let's discuss about these two in more detail. So any patient who develops heart failure, first of all, let me draw a picture for your better understanding. So let's say this is the heart. I think I discussed a little bit about it in our previous session, but today we are going to discuss it more. So this is the heart. These are the 4 chambers that we can see. And blood comes from superior vena cava and inferior vena cava, and it gives the blood, deoxygenated blood, into the right atrium. It goes to your right ventricle through the tricuspid valve. And from the right ventricle, blood will go through the pulmonary arteries into the lungs. And the valve in here, it will be pulmonary valve. So through the pulmonary valve, blood will enter into pulmonary artery and it goes to the lungs. And in the lungs, this deoxygenated blood will get oxygenated. And then from lungs, pulmonary vein will carry the oxygenated blood into the left atrium. From left atrium, through the mitral valve, blood will go to the left ventricle. And then from left ventricle through aorta, blood will go to the whole body, right? So this is how oxygenated blood will reach to the body. So this is a normal physiological mechanism. In case of congestive cardiac failure, this normal mechanism will be hampered. How? So most of the time, the left ventricular failure can occur due to a lot of reasons. Sometimes it can be like patient's contraction of the heart is not that good. So what happens in systole and diastole? That's the normal thing that we need to know. In systole, your heart contracts and it pumps the blood into your body. So systole means contraction of the heart. And what happens in diastole? Your heart gets relaxed and it takes in all the blood from the extremities. So diastole is a relaxation phase and systole is the contraction phase. And heart failure can happen due to any issues in systole functions or diastole function. Let's say someone's heart is not contracting well. So if the contraction is the problem, okay, then that patient will develop systolic heart failure. Someone's systole is good, that means contraction or pumping is all right, but it can't relax properly. So if the heart can't relax properly, it can't receive blood from the extremities. And if heart doesn't get enough blood, it can't pump enough blood to your body. So if someone's relaxation is problem, then it will cause diastolic heart failure. In diastolic heart failure, systole or contraction or pumping is good. And that's why ejection fraction, which is mainly the systole, ejection fraction will be normal in case of diastolic heart failure, even more than normal sometimes. But in case of systolic heart failure, ejection fraction will be low. That means ejection fraction depends on the systole, how much blood your heart can pump out. That's the measurement of your ejection fraction. So if systole is not good, ejection fraction will be low. And that's what we call systolic heart failure. Okay, so we need to know these two subtypes because the treatment is different for systolic and diastolic heart failure. So if we don't know which heart failure this patient having, we might end up giving a wrong medication. Then the second thing, that when your heart is not pumping enough blood, what happens? As shown in the video, that kidney also get the idea that, well, I'm not getting enough blood, so let's restore or let's retain some blood so that I don't die out of dehydration or out of hypovolemia. So your kidney will sense that, and kidney will retain salt and water. And that retention of salt and water will lead to congestion or accumulation of fluid in almost every part of the body. So that will be manifested through lung congestion. So lung will be edematous. So there will be fluid accumulation in your lung, and that will lead to dyspnea or shortness of breath. And because when you lie down, what happens? All the fluid from your body will come to the dependent part, and dependent part is the lung. So when you lie down, all fluid comes into your lung and it just drowns the lung. And that's why in heart failure patient will get more shortness of breath when they lie down. So orthopnea. And they always say they need to use more than one pillow during sleeping. Okay. Apart from this, like lung pleural effusion or lung effusion, what else patient can develop? There can be congestion in the jugular vein, and that will be manifested as raised JVP. Okay. After that, once jugular vein is getting distended, the other part, like other veins, will also start getting distended. So hepatic vein gets distended, causing hepatic congestion. And sometimes patient with heart failure can give you a tender hepatomegaly. What other you can get? You can get abdominal discomfort because of ascites, because there will be fluid accumulation in the peritoneum as well. And eventually patient will also develop edema or fluid accumulation in their lower leg. Because fluid is getting accumulated, patient will gain weight. So these are your features in these cases, right? So patient develops dyspnea, especially on exertion, orthopnea. Some patient also develop dry, irritating cough, and sometimes in acute pulmonary edema, patient also develops a frothy pink sputum. Lethargy, fatigue, weight gain, ankle edema, and abdominal discomfort due to hepatic congestion or ascites. Because of poor cardiac output, that means your heart is not pumping enough blood to the brain, and brain is not getting enough oxygen, you develop dizziness, you develop sometimes blackout or syncope. Syncope means loss of consciousness. Clear? So this is the pathophysiology of all the symptoms and signs of heart failure. We will move into detail again, don't worry. Now, heart failure, depending on which side has get failed, you can say it's either left heart failure or right heart failure. So left heart failure means the left ventricle is not pumping enough blood, and right heart failure means right ventricle is not pumping enough blood. Or it could be problem with relaxation of the ventricles. The main features in left heart failure is that what happens, let me draw this picture again, and then you will understand it very clearly. Remember, I told you that Let me change the color so that it's more evident. Let's say this is your aorta. And let's say this is pulmonary artery going into the lungs. Okay, so what happens in this case? Some patients, let's say someone develops left heart failure, which means left heart is not pumping enough blood. So what happens in the left ventricle? Blood is getting accumulated in left ventricle. When left ventricle is totally full, there will be fluid accumulation in the left atrium. Okay, so what's happening? That means when this, like, just think it as some bottle. If this bottle is filled up, then this will get filled up eventually. And what happens? Pulmonary veins from the lungs carry blood into the left atrium. So eventually what will happen? This pulmonary vein will get congested, and then the lung will get congested. And then what will happen? This pulmonary artery will get congested. Once pulmonary artery gets congested, or there is increased accumulation of fluid in here, what will happen? So let's say there is lots of blood accumulated in the pulmonary artery. That is what we call pulmonary hypertension. When pulmonary hypertension develops, your right ventricle needs lots of increased pressure than before to pump blood from the right ventricle into the pulmonary artery. So to overcome that pressure in the pulmonary artery, right heart needs to work harder, and eventually right ventricular hypertrophy happens and followed by right ventricular failure. Once the right ventricle fails, right atrium will also get accumulated with fluid, and then the whole body will get congested. So see that this is backflow of congestion. So it all starts eventually from the left ventricle, and then this is a gradual process of congestion in the body. So eventually, right heart failure occurs due to left heart failure. So if someone asks you what is the most likely cause or what is the most common cause of right ventricular failure or right heart failure, what you will say? Left heart failure. Okay. Now, left heart failure or left ventricular failure can be due to a lot of causes. Most common cause is acute myocardial infarction. Okay, but there are also other causes. We will discuss it. Now, if someone develops left ventricular failure, eventually they get pulmonary edema. And the main feature of left ventricular failure is pulmonary edema. And most of these patients with left heart failure present to you acutely with shortness of breath because of acute pulmonary edema. Okay, APO. So acute pulmonary edema, usually it's a complication of left ventricular failure. So when someone develops pulmonary edema, what will happen? So patient will have dyspnea or shortness of breath. They will have orthopnea, right? Give you S3 gallop rhythm. Patient will also have bibasilar crepitation in their lungs. That's very important finding in left ventricular failure. So these are your features. Now you can easily find it out. See, mainly the features that you will look for is gallop rhythm. You look for bibasilar crepitations. Sorry. So you look for bibasilar crepitation, gallop rhythm, and also eventually this patient will develop other feature of congestion. Right heart failure, the main feature that you will get is the elevated JVP and all the edema like hepatomegaly because of hepatic congestion, pedal edema because of ankle swelling. If you go through this one, you can eventually understand it because inferior vena cava carries blood from your extremities, lower extremities. So if inferior vena cava eventually gets congested, what will happen? Peripheral body swelling will start. Same with this one, SVC, superior vena cava can get congested sometimes, and you can get a jugular venous distension eventually. So raised JVP, hepatomegaly, ascites, peripheral edema, these are all features of right heart failure. Okay, whenever you get features of congestion, immediately you call it as a congestive cardiac failure. Congestive cardiac failure is actually a combination of left and right heart failure. Okay, so what are the physical examination findings you can get? All you can get it. So you can get bivascular crepitation, peripheral edema, ascites, hepatomegaly, raised JVP, and if it's a systolic heart failure, you can also get a displaced apical impulse. So right now you should understand that what are the features of left heart failure and what are the features of right heart failure. Okay, any questions up to this? Now let's have a look to this video just to give you the best idea about it. And that's very important to understand because all the treatment, all the investigation depends on this specific part.
Heart failure occurs when the heart is unable to provide sufficient blood to meet the body's needs. Heart failure is not a disease on its own, but rather a consequence of other underlying conditions. The impairment of the heart function can be due to an inability to pump effectively during systole, called systolic heart failure, or inability to fill properly during diastole, called diastolic heart failure. Heart failure can be right-sided or left-sided, depending on the side that is affected. About 2/3 of all left-sided heart failures are caused by systolic dysfunction. In systolic heart failure, ventricular contraction is compromised. This may be caused by any condition that weakens the heart muscle or creates more difficulty for the ventricle to pump. The most common include coronary artery disease and its consequences. Plaque buildup narrows the coronary artery, reducing blood supply to the heart muscle. Complete blockage can cause heart attacks, which often leave behind non-functional scar tissue. Dilated cardiomyopathy. The ventricular wall is dilated, becomes thin and weak. Hypertension. Higher systemic pressure makes it harder for the ventricle to eject blood. This is because the pressure in the left ventricle must exceed the systemic pressure for the aortic valve to open. Valvular heart disease. Damage to the valves, such as stenosis, also makes it more difficult for the ventricle to pump. The effectiveness of ventricular contraction is measured by the ejection fraction. Typically, the left ventricle is filled with about 100 milliliters of blood, but only 60 milliliters is ejected during contraction. This corresponds to an ejection fraction of 60%. The normal range of the ejection fraction is between 50 and 70%.
So we call it like 45 to 65% is normal.
When ventricular contraction is impaired, the volume of ejected blood is reduced, and so is the value of the ejection fraction. In systolic heart failure, it drops below 40%. In diastolic heart failure, the ventricle is filled with less blood. This may be because it is smaller than usual, or it has lost the ability to relax. The ejection fraction may be normal, but the blood output is reduced. The ejection fraction is therefore commonly used to differentiate between systolic and diastolic dysfunction. Examples of conditions that can lead to diastolic heart failure include hypertrophic cardiomyopathy. The heart muscle grows thicker than usual, leaving less room for blood filling. Restrictive cardiomyopathy. The heart muscle becomes rigid, unable to stretch. Hypertension can also cause diastolic dysfunction indirectly via compensation mechanisms. As higher systemic pressures make it more difficult for the ventricle to pump, the heart compensates by growing thicker muscle to try harder. Larger muscle means reduced space for blood filling. Regardless of being systolic or diastolic in nature, left-sided heart failures share a common outcome: less blood pumped out from the heart. As a result, blood flows back to the lungs where it came from, causing congestion and increased pulmonary pressure. As this happens, fluid leaks from the blood vessels into the lung tissue, resulting in pulmonary edema, a hallmark of left-sided heart failure. Accumulation of fluid in the alveoli impedes the gas exchange process, resulting in respiratory symptoms such as shortness of breath, which worsens when lying down, and chest crackles. Right-sided heart failure is most commonly caused by left-sided heart failure. This is because the increased pulmonary pressure caused by left-sided heart failure makes it harder for the right ventricle to pump into the pulmonary artery. This results in systolic dysfunction. In compensation, the right ventricle grows thicker to pump harder, which reduces the space available for filling, eventually leading to diastolic dysfunction. Other common causes of right-sided heart failure include chronic lung diseases, which also raise pulmonary blood pressure. As the right ventricle pumps out less blood, the blood again backs up to where it came from, and in this case, the systemic circulation. This results in abnormal fluid accumulation in various organs, most notable in the feet when standing, sacral area when lying down, abdominal cavity, and liver. The fluid status can be assessed by examining the distension level of the jugular vein. Heart failure is usually managed by treating.
Okay, so that should give you a very good idea about what we have been discussing so far. Now
the
let's
underlying.
So we should understand by now that what is systolic versus diastolic heart failure. And also the ejection, if you just look at the ejection fraction, you will already understand. Like if ejection fraction is normal, it's diastolic heart failure. If it is less than normal, that's systolic heart failure. Now come to the causes of heart failure. So causes can be systolic. What are the systolic heart failure causes? As we have been discussing, these are the causes. Ischemic heart disease is the most common cause. Sometimes hypertension can cause it. Okay. For diastolic heart failure, hypertension, diabetes, sometimes ischemic heart disease can cause it. But for diastolic heart failure, it's mainly the heart is not getting relaxed properly. So what causes this relaxation problem? Like hypertrophic cardiomyopathy, restrictive cardiomyopathy, these are more commonly related with diastolic heart failure. Now come to the next question, which is very favorite for AMC. Someone came to you with heart failure symptoms, as we have been discussing. And the question asking you, what is the next most appropriate investigation for this patient? Now, you need to understand what they mean by next most appropriate. These are the terms you will get a lot in your questions. So next most appropriate means initial, or that means how you're going to proceed. Okay, it doesn't mean the definitive test they're asking. So what is the next most appropriate test for someone who is having features of heart failure? Guys, what do you think? So I can see there is ECG and echo. So tell me one thing. Someone like this came into your emergency department. Will you send the patient immediately for an echocardiogram, or you will do an ECG first? Remember, I told you that patient in here, what is the most common cause of having an acute heart failure? Ischemic heart disease or myocardial infarction, right? So why not doing an ECG first? That's the trick in these questions. We know that echocardiogram is the most appropriate test or definitive test for heart failure. But if the question asks you, what is the initial test? What is the next most appropriate test? That should be ECG, guys. A lot of people get it wrong, and I can see most of you also got it wrong. Okay, so please remember these sort of things in the exam. So echocardiogram is the investigation of choice, obviously, because it gives us the ejection fraction and we can confirm that it's a heart failure or not. Now, some people also do BNP, B-type natriureteric peptide. It's a hormone which is secreted from ventricular myocardium. Now, do we do BNP to diagnose heart failure? Or if I ask you, what is the role of BNP in heart failure? So can you do BNP to diagnose heart failure or for severity and prognosis? Remember, BNP we do, like we know that this patient having heart failure, okay? And then to know the prognosis or severity of heart failure, we do BNP. BNP is not a diagnostic test of heart failure. Remember that, okay? So it's just for prognosis or severity. But sometimes, like, let's say you are in a rural hospital and you don't have any echocardiogram available. Now, you think that this is heart failure but can't confirm. Then you can do a BNP, okay? But where echocardiogram is available, you should not do BNP to diagnose heart failure. Okay, so that's what we have been discussing, the diagnosis part. The next is heart failure management, stepwise management. So usually if it's a systolic heart failure, you should always start with ACE inhibitor. That's your first medication. Okay, patient is not getting better with ACE inhibitor. The next option is to add furosemide. That's not helping. Then you can add spironolactone. Still congestion, then you can add beta blocker. And last option is digoxin. Previously, a lot of candidates, like a lot of doctors also use digoxin as a first-line medication of heart failure. But nowadays, that's the last resort. Never use digoxin immediately. Okay? Only time we use digoxin initially, like if someone having atrial fibrillation, with that patient also having heart failure. And we started metoprolol or any other beta blocker, but still patient is not getting back or patient is having severe symptoms. Then we can give digoxin. So atrial fibrillation with heart failure, second line treatment will be digoxin. Now, the beta blocker, we don't give beta blocker in every heart failure patient. Only the patient who are euvolemic at the moment, that means a stable CCF, for that patient, you can give beta blocker. Okay, so like someone having acute pulmonary edema or acute worsening of their shortness of breath, they're having decompensated heart failure, BNP is sky high. You are not going to give them beta blocker at that time. Because what will happen? Beta blocker can decrease the pumping action of your heart. Your heart is already failed. And if you're decreasing the pumping, it can eventually get a lot worse. Okay, but when these things gets euvolemic, patient gets more stable, then beta blocker has a cardiovascular mortality benefit in this patient. So that's why we use that. But always use beta blocker in a stable heart failure patient. So in case of systolic heart failure, this will be our stepwise approach: ACE inhibitor, furosemide, spironolactone, beta blocker, and digoxin. Okay, so you have to remember this. Now, lots of candidates get it wrong. Do we use furosemide in every heart failure patient? No. Only patients who develop congestion, and that congestion is especially causing symptom, like patient having dyspnea due to congestion. So let's say a heart failure patient coming to you, only problem this patient is having is swelling of their ankles, but no dyspnea, okay? Like even like it can be like a mild dyspnea, not very severe dyspnea or orthopnea. And there is no crepitation in the base of the lung. So only thing that you have found out, there is some knee or ankle congestion. We don't need to give furosemide for that patient. Furosemide only you use after ACE inhibitor, but you can use that if someone having orthopnea or dyspnea due to acute pulmonary edema. So when acute pulmonary edema, or you can say when fluid accumulated in the lungs and patient is symptomatic for that, then you should start using this furosemide, or then next approach will be adding it spironolactone. Is this sounds clear for everyone? Because questions come from here. So this is what we have been discussing, ACE inhibitor or ARB. Let's say you started ACE inhibitor and patient having worsening dry cough. What you will do? Yes, change to ARB. Okay, so that's because ACE inhibitor can cause dry cough and it can be quite irritating. So anyone develops dry cough or any kind of cough, after starting ACE inhibitor, you just switch it to ARB. Okay, so ACE inhibitor not helping, then you can start with diuretics, which is furosemide. Not helping, you can use spironolactone. If patient is stable, then you can add selective beta blocker. Okay, and last option will be digoxin. So this is what I was talking about. Chronic adrenergic activation has been implicated in the pathogenesis of heart failure, and thus beta blocker are an important part of heart failure therapy. Along with ACE inhibitors, beta blockers have demonstrated to decrease mortality, reduce hospitalization, improve functional class. So it's a very good drug, but only you give beta blocker after a stabilization of symptom with a diuretic and ACE inhibitor. Okay, and you don't need to think about blood pressure when you start a beta blocker, because beta blocker doesn't have much effect on blood pressure. Rather, its main effect is on your heart rate, because you are giving selective beta blocker, which is your metoprolol, carvedilol, bisoprolol, these medications. Now come to diastolic heart failure. The basic management will be managing the underlying cause of it. Like if patient is hypertensive, control the blood pressure. Okay, if it's diabetic, control the diabetes in that way. But if you want to treat diastolic heart failure patient, you should start with a calcium channel blocker and beta blocker. Okay. So basic treatment is with ionotropic agents such as calcium channel blocker, which is verapamil or diltiazem, and beta blocker. Why? You are giving some heart rate blockers. And when you give this calcium channel blocker, which is a rate limiting calcium channel blocker, and a beta blocker, what it will do? It will decrease the heart rate. Remember the pathophysiology of diastolic heart failure? Its main problem is that it cannot get relaxed. And as it cannot get relaxed enough, blood cannot get accumulated in the heart, and a small amount of blood is there, and that's only get pumped out. Right? So now if you can give your heart more time to get relaxed, okay, before it pump it out, it will help in this case. So if you can just reduce the heart rate, if you reduce heart rate, contraction will be reduced, or at least that pumping or contraction effect of the heart will be reduced, and heart will get enough time to get the blood. Okay, so for diastolic heart failure, that's why calcium channel blocker, beta blocker are very good. Try to avoid diuretics, except patient is congested, digoxin, vasodilators, or nifedipine. Why? Because you don't want to give any medication which causes hypovolemia or which causes peripheral vasodilation. Okay, So no diuretics. If you give diuretics, patient will develop hypovolemia and heart is not getting enough blood. And if you are removing blood from the body on the top of it, again, it will get worse. But if someone is congested too much, then we can give it in this case, otherwise not. Okay, so that's important for that. And also ACE inhibitor is not the first line in diastolic heart failure. For diastolic heart failure, you use either calcium channel blocker or beta blocker as a first line treatment. Sometimes they ask you which one of the following medication has survival benefit in congestive heart failure. These are the three medications which has survival effect, no other. Digoxin has no survival benefit. Okay, so ACE inhibitor, beta blocker, and spironolactone. So we discussed about our pulmonary edema, right? So in case of pulmonary edema, what will happen? You will get basal crepitation. You will get, if you do a chest X-ray, you can get a finding in the chest X-ray like lung will be overloaded with fluid. Let's see if we have any X-ray for that. So we'll come to a pulmonary edema later on. Okay, so just wait there. Let's move on to some of the medications that we use and what are their complications, because some medications which you use in cardiology, it's very commonly asked, especially their complications. So this is very important to know about it. Like you have thiazide diuretics, which you can use for hypertension, like hydrochlorothiazide. What thiazide diuretics main complications are? It can cause hyponatremia, hypokalemia, hypercalcemia, hyperuricemia, and if it causes hyperuricemia, it can eventually cause gout also. So gout patient, you should never ever give thiazide diuretics. Okay, it can also cause agranulocytosis and it can cause glucose intolerance. So diabetic patient, you don't give thiazide diuretics. Okay, and also remember hyponatremia, hypokalemia, and hypercalcemia. Indapamide is also kind of thiazide diuretics. Okay, the site of action is more or less same. Complication is also same, but hypokalemia and lipid abnormalities are less common. These thiazide diuretics also can cause dyslipidemia, or especially it can increase triglyceride in the blood. Okay, so indapamide has less chance, but indapamide is very notorious to cause hyponatremia, and it comes in exam so many times. Okay, remember it. Loop diuretics like furosemide, bumetanide, which is commonly used, it can cause hyponatremia, hypokalemia, hypocalcemia. So everything is hypo in here. Two important complications is that it causes ototoxicity. Okay, it can cause agranulocytosis. Then you have spironolactone. Very important to understand that this is the only hypertensive drugs, or you can say cardiology related drug, one of it which causes hyperkalemia. Others, as you can see, causes hypokalemia. So spironolactone causes hyperkalemia and also it causes gynecomastia. This is the commonest drug which causes gynecomastia. Tell me another drug in terms of cardiology which causes gynecomastia. So one is a spironolactone. What is the other drug? Yes, digoxin, right? Dr. Jainab, very good. If you have both in option, which one you will choose? Digoxin or spironolactone? Spironolactone, because that's most common. Okay, so these are common scenario in exams. They give you a gynecomastia patient, okay, and they will give you that this patient has been started recently on digoxin, spironolactone, and some other medication, and then they will ask you what is the most likely cause. in the option, both digoxin and spironolactone are there. Okay, so you need to know about these things. Always common things should be the first choice. Now, as we have been discussing about digoxin, sometimes a lot of patient is still on digoxin. So we need to know the complication of it because it has a high possibility of causing toxicity. What digoxin actually do and how it function, right? And how it helps in heart failure. Digital is it inhibits sodium-potassium ATPase pump, and that result in increased intracellular concentration of sodium and decreased exchange of intracellular calcium. So sodium-potassium ATPase pump, what happens actually is that sodium will go outside and potassium will come inside the cell. Now, if digoxin block it, what will happen? There will be increased intracellular sodium, right? Now, normally what happens when sodium goes out, calcium goes in. As sodium is not going out, there is decreased calcium in the cell. And calcium, usually what it does, it causes contraction of your cell, right? So let's have a look in here, what actually it does. Let's say this is one of the cell. Sodium, potassium, ATPase pump is here. Okay. So normally what is supposed to happen is that sodium will go outside the cell. So this is your interstitial space. And potassium will come inside the cell through this pump. Digitalis will inhibit that. When sodium goes outside, okay, calcium from inside the cell, it also, like there will be an exchange of intracellular calcium for extracellular sodium. Okay, so sodium can again come back in exchange of calcium. But now sodium is not even going out, so this exchange is not happening. What is happening now? So now there is increased calcium inside the cell. And calcium causes ionotropic effect. That means it causes contraction. Okay, so digoxin increases this intracellular contraction and it increases the contraction of the heart. Okay, so if contraction is increased, then sometimes if someone having problem with pumping, if you give digoxin, then that will be alleviated by it. So the main function of digoxin is increased cardiac contractility. Now the problem happens in here is that this sodium potassium ATPase pump, there is a receptor in here, right? Digoxin compete with potassium to get into the cell. So it has the same receptor. So digoxin and potassium, it shares same receptor to go into the cell. That means if any of these tools concentration is high in the blood, the other one will not be able to get attached to this receptor. What does it mean? Let's say someone having hypokalemia. That means in the blood, their potassium is low. So if potassium is low, then digoxin will be easily going into the cell. And sometimes that can result in digoxin toxicity. Okay. Now, if more digoxin is going into the cell, more potassium is outside the cell, or you can say in the plasma. And someone who develops digoxin toxicity, eventually that will cause hyperkalemia. So it's a lot of complications, right? So the only thing that you need to remember is that if someone has hypokalemia, it can cause digoxin toxicity. And digoxin toxicity itself can cause hyperkalemia. Is this clear, guys, a little bit? Okay, good. Apart from this hypokalemia, some other things can also increase the risk of digoxin toxicity. Like if someone having kidney failure, any other electrolyte imbalance like hypercalcemia, hypomagnesemia. Okay, someone having hypothyroidism can also get digoxin toxicity. And also there are some other drug you can go through it. The toxic effect of digitalis can be manifested by nausea, vomiting. That's the commonest symptom. Gynecomastia, blurry vision, yellow halos around the object. And digoxin toxicity can cause almost every arrhythmia in your heart. But most commonly, it causes this premature ventricular complex. It can also causes paroxysmal atrial tachycardia, and sometimes even it can cause bradycardia or eventually heart block. Okay, so remember that. And sometimes even if your due digoxin level that can be normal, but patient actually having digoxin toxicity. Okay, so normal digoxin level in the blood does not rule out the possibility of digoxin toxicity. So if patient having symptoms, you should consider digoxin toxicity. You will stop the drug, and if patient having acute symptoms and it involving the heart as well, start with the DG bind, which is an antidote. Let's move on to pulmonary edema. Pulmonary edema is a medical emergency because this patient the lung gets drowned with fluids. Okay, and because there will be decreased gaseous exchange, eventually patient can go through the respiratory failure also. If you look at the chest X-ray in a pulmonary edema, you will find out, see that the cardiac silhouette or cardiac shadow you cannot see properly, right? And it's obviously dilated, right? The most important finding, as you can see, this is called Batwing Sign or perihilar edema, or you can see lots of vascular markings, lots of whitish opacities around the hilum. Okay, this is called Batwing appearance, which you can find out in acute pulmonary edema. Okay, as you can see here also. We already know what we will find out in symptoms. We will find what is, and also signs. The treatment is first put the patient in propped up position. Okay, because lying down can cause it more worsening of the symptom. Patient will develop hypoxemia, so give oxygen if needed. And then eventually this patient will need ACE inhibitor and diuretics. Diuretics is must if someone develops pulmonary edema. Sometimes you can also give morphine because patients in these stages, they get a lot of anxiety, and morphine can relieve this anxiety in a heart failure patient. Clear? So that gives you all heart failure related questions. I don't think you will never ever miss any heart failure related questions after this discussion. Do you guys have any question in your mind? Good. Now let's take a 10-minute break, okay? And then we will discuss about valvular heart disease and hypertension. Ten-minute break, okay? All right, guys, let's start again. So I can see some questions in my box. So Aboriginal female does not have access to medical facilities with 3 months dyspnea brought by her friend. On examination, basal crepitation and diastolic murmur is there. Anytime there is Aboriginal thing is written in your question, that and patient having features of heart failure, okay, you should think about rheumatic heart disease immediately. Most likely this patient has got rheumatic heart disease because of Aboriginal, because that's the most common cause. And as you can see, there is diastolic murmur. Most that can be aortic or any of the valvular disorders. Okay, we'll go through the valvular defect just now, and you will know where we get diastolic and systolic murmur. Okay, so even if it's a rheumatic heart disease, the next step, if they ask, we should always do a ECG first. Always. Next step, any heart-related condition, it's ECG first. Okay. So yes, next means is the first basic investigation, and most appropriate, if they don't add next, just most appropriate, best test, or they say that what is the diagnostic test, all these will be confirmatory tests. That means echo, then you can say. Now, valvular heart disease, actually, your GM doesn't have any valvular heart disease. So, and we don't have to discuss a lot about it. Only thing that you need to remember is the type of murmur from these valvular heart diseases. So type of murmur is one of the craziest thing I would say, like just to remember all the type of murmurs and everything. Today, I'm going to show you one of the very good and easy way to remember this valvular heart defects and type of murmur. Okay, let's go on. Now, first of all, we just need to remember one specific murmur, which is the murmur of mitral stenosis. And that's the commonest valvular heart defect and more common in Aboriginal patients. So mitral stenosis, what is the murmur that we get? We get a mid-diastolic murmur, MDM. Okay, so mid-diastolic murmur, that's your mitral stenosis. There are some other description of this murmur. We will go through that later on, but just to start, okay? So mid-diastolic murmur. In case of murmur, the most important murmurs are from mitral valve and aortic valve. Tricuspid and pulmonary usually haven't seen to come in exam anytime. So you just concentrate on these two. From this MS murmur, you can find out all the other 4 murmurs related with mitral and aortic valve. Let's see how we can do that. So mitral stenosis, that's a diastolic murmur. Now, what is the opposite of mitral stenosis? Opposite means, remember I talked about either mitral or aortic. So opposite of mitral is aorta. And what is the opposite of systolic? Sorry, what is the opposite of stenosis? Regurgitation, right? So aortic regurgitation. Aortic regurgitation also will give you a diastolic murmur. And it's most likely early diastolic murmur you can get. And we'll discuss about it, but don't worry, we just need to know which one is diastolic and which one is systolic murmur. And you will be able to exclude a lot of options just by knowing that. Okay, now from here we can also find out the other one. So if MS is diastolic murmur and AR is also diastolic murmur, let's have a look to the aortic regurgitation. Aortic regurgitation murmur is early diastolic decrescendo murmur at the left sternal border, and it's a high-pitched murmur. You only need to remember diastolic, and everything is not very important. Like other like decrescendo murmur, crescendo murmur, that usually doesn't come in exam. Okay, now what will be the murmur of AS and what is the murmur of MR? So we have got AS, we have got MR. So aortic stenosis and mitral regurgitation. Always remember, if MS is diastolic, AS will be systolic. Okay. If AR is diastolic, okay, what will be MR? Systolic. So we're just playing with the opposite word. Okay. Other than this, if you can't remember that, you can just remember in that way. So if MS is mid-diastolic murmur, so it's a diastolic murmur. So what will be the murmur of the opposite of MS? So M opposite is A, aorta, and S opposite is R, regurgitation. So that's also a diastolic murmur, and this is an early diastolic murmur. Okay. Now, if we come to the other two, what is the other one left from MS? MR. What is the other one left for AR? AS. These two will be systolic. Okay. So MR is systolic murmur. AS is also systolic murmur. AS gives ejection systolic murmur that radiate to the neck. MR gives pansystolic murmur or hollow systolic murmur that radiate to the axilla. So these two murmur, MR and AS, radiates. Other two murmur doesn't radiate. Okay, now you see this is very easy. You just need to remember MS murmur, and eventually you will be able to find out the other three also. And these four usually what it comes in exam. Is this helpful for you guys? I hope so. So now just move on. So just go through these things. So aortic stenosis murmur is loud murmur. It's a crescendo decrescendo murmur. And the main thing that you need to remember, it's the ejection systolic murmur. And it can get radiate to the neck or carotid. Mitral regurgitation, it's a high-pitched hollow systolic murmur radiating to axilla. Mitral prolapse, just remember mid-systolic click, nothing else. Mitral stenosis, it's a rumbling mid-diastolic murmur. Aortic regurgitation, high-pitched early diastolic murmur. Now the positions, that's also important. So sometimes they ask you, or what is the position of murmur, where it is best heard? If this is your sternum in the middle, okay, and let's say this is the second intercostal space. So this is second, this is third, fourth, fifth. In the fifth intercostal space, usually you get apex of the heart in here. Okay, and mitral murmur are best heard at the apex. So in the apex, which means in the left fifth intercostal space, you will be hearing MS or MR murmur. That means all the mitral murmurs. Okay, then come to aortic murmur. The thing is, aortic murmur are best heard in the right side, not in the left side. Why? Because normally this is what happens. So aorta usually arises from the left ventricle from here, and it turns like that. So in the right second intercostal space, you get more specific murmur. Okay. So for aortic stenosis, the murmur is best heard in the right second intercostal space. So this gets confusing because we know that aorta is a part of left side, right? So this is where a lot of candidates get it wrong in the exam. So aortic stenosis murmur will be best heard on the right second intercostal space. But one of the exception is aortic regurgitation. It should also should be best heard in this area, but no, aortic regurgitation is best heard in the left fourth intercostal space along the sternal edge. This is what you just need to remember. Okay, so for your aortic regurgitation, the murmur is best heard in the left fourth intercostal space along the sternal edge. This left second intercostal space, this is for pulmonary valve, like pulmonary stenosis, you will get in here. Is this clear for everyone? All right. So if we just go through this murmur again, so remember the mid diastolic murmur. This is for MS, mitral stenosis. So always remember, what is the opposite of MS? M is mitral, so opposite is aorta. So we are just dealing with mitral and aorta, not pulmonary or tricuspid, because those usually doesn't come in exam. What is the opposite of stenosis? Regurgitation. So aortic regurgitation, also diastolic murmur, but it's not mid diastolic, it's early diastolic. Now what is left? So MS, so left is MR, and what is left from aortic? AS. So AS and MR will be systolic murmur. AS or aortic stenosis gives ejection systolic murmur, which radiates to the neck. MR, mitral regurgitation, gives a pansystolic or hollow systolic murmur radiating to the axilla. Okay, so this is how you can easily find it out. Any questions so far? Now, I want you guys to go through this med bullet guideline. It has all the murmurs very well written also. So go through that in your own time, please. Let's move on. So we have three types of cardiomyopathy. Cardiomyopathy means the problem is in the myocardium. So we have dilated cardiomyopathy, hypertrophic obstructive cardiomyopathy, and restrictive cardiomyopathy. Dilated cardiomyopathy, in here, your ventricles get dilated, and if it gets too much dilated, the ventricle will be thinner. And because it's thinner, it cannot pump the blood eventually. So if it cannot pump the blood, what type of heart failure you will get here? Systolic, right? Very good. So systolic heart failure, right? So in case of dilated cardiomyopathy, the features will be just similar like systolic heart failure. These are the causes of dilated cardiomyopathy, and mostly like it's idiopathic, most common. Then alcohol very commonly causes dilated cardiomyopathy. Then myocarditis, some toxin can cause it, some medication also can cause it. The treatment is same treatment as if you are treating a systolic heart failure patient. That means ACE inhibitor, beta blocker, spironolactone, all these things. But these patients eventually might need heart transplant because the prognosis is not very good. And if their ejection fraction is less than 35%, the best approach will be put on an implantable defibrillator because it can decrease the risk of sudden cardiac death. So look at the dilated cardiomyopathy. So the ventricle, the thickness in here and in here, you can see the thickness has been got very, very thin myocardium in here. Okay, and this is the normal one. So that's what we call dilated cardiomyopathy, eventually causes systolic heart failure. The next one is hypertrophic obstructive cardiomyopathy. Look at the term hypertrophic obstructive cardiomyopathy, which means this will cause hypertrophy of the cardiac muscle. And eventually it causes obstruction of something. This is a genetic disorder and it's an autosomal dominant disorder. Okay, the distinctive hallmark is unexplained myocardial hypertrophy and eventually thickening of the interventricular septum. So look at the interventricular septum in here and look at this one. So normally it causes hypertrophy of the interventricular septum. If it is too much hypertrophic, you can see that it can block the aortic area, right? So now the blood needs like very hard work to go into this small hole to get out of the heart into the aorta. So the heart is unable to relax properly, right? So there is lack of space in here to fill the heart with blood. So what type of heart failure you will get in here? Diastolic, very good. All right, so very good, guys. So you guys are getting it really quickly. So diastolic heart failure you will get in here. So that's what we've called as a hypertrophic obstructive cardiomyopathy. So in here, because of the hypertrophy, left ventricular compliance is reduced, but systolic performance is all right. So ejection fraction will be normal. Even in this case, even because the ventricle is hypertrophic, it can pump the blood very quickly. So sometimes you will get ejection fraction 80 to 90%, okay, which should be normally 45 to 65. Clinical manifestation will be similar like before. So in this case, patient will get all the features of heart failure. The very important in here is that how come, because it's a genetic one, sometimes in the question you can get a clue that there is a sudden cardiac death history in the family, especially young age. Like father died at very young age due to a sudden cardiac death. Okay, so that's the clue for hypertrophic obstructive cardiomyopathy. And young children, like young or just a teenage people, can present to you with a sudden syncopal attack, nothing else. So patient was, let's say 13-year-old girl was playing and suddenly she just fall on the ground and she lost consciousness. There was no prodromal features or anything. So she just fall without any prodromal feature, had a loss of consciousness, regained the consciousness, and then there was no confusion after that. So that's your syncope. And that's one of the presentation of who-come. Who-come can get a lot worse during exercise. Because if you look at the picture in here, obviously through the aorta, a lot of blood cannot get out. Now, when you are exercising, your body needs more oxygen and blood, but because of this obstruction, your body is not getting that. If blood cannot go out into the aorta because of obstruction in this area, eventually your brain will not get enough blood, and that will result in syncope or loss of consciousness. Okay, so that's who-come. Any who-come patient, the initial or next investigation is ECG, not echocardiogram. So ECG, most of the time it will be normal, but sometimes you can get left ventricular hypertrophy. Main or most appropriate investigation is echocardiogram. Question gets lots of complications in here, like complex questions come. You did echocardiogram in this patient, but it came normal. What is your next thing? The next thing is to do a stress echocardiogram. So you ask the patient to do exercise, or you can give chemicals to make the heart exercise, and then you do a echocardiogram. Sometimes a stress echocardiogram can pick it up. Okay, so always remember, if your resting echo is normal, the next is a stress echocardiogram in this case. Because it causes diastolic heart failure, the treatment will be beta blocker, calcium channel blocker, those things. Try to avoid digoxin, diuretics, vasodilators, and exercise, because this thing can cause it worsening of the obstruction. Restrictive cardiomyopathy, not very common, okay, but it causes rigidity of the ventricular walls. If ventricle gets rigid, it cannot move, and if it cannot move, it cannot pump blood, right? So in this case, what can happen? Because ventricle gets rigid and non-compliant, it cannot relax properly. So it causes diastolic dysfunction, and also it cannot contract properly. So eventually it can cause systolic dysfunction. So this patient develops both type of heart failure, systolic and diastolic. It's a very bad prognosis. Usually death occurs unless you do heart transplantation. And most common cause of death is usually from heart failure or arrhythmias. Again, initial investigation ECG, best is echocardiogram. What is the cause of restrictive cardiomyopathy? It can be anything infiltrative like sarcoidosis, amyloidosis, hemochromatosis. Okay. Come to acute pericarditis. Acute pericarditis, remember we discussed a little bit in our chest pain. So how it presents? The patient will present to you with a chest pain, and the pain gets worse after taking deep inspiration, coughing, and also lying down, but get better when they lean forward. And it's a sharp stabbing kind of pain. It doesn't get radiated anywhere else. Okay, so, and also they give a previous history of viral infection. That's the usual causes. Apart from viral infection, it can be due to connective tissue disorders, can be due to disorders of metabolism, like someone having uremia or kidney failure. It can cause uremic pericarditis. Neoplasm, trauma, and inflammation. Only treatment that you do in here is give some aspirin or NSAID, and initial investigations is ECG. ECG can diagnose pericarditis. You don't need to do anything else. Sometimes if you get a patient that you have given aspirin or NSAID, still it's not improving, you can add colchicine also. And sometimes even you can add steroids. Next, pericardial effusion. Pericardial effusion, just like pleural effusion, when there is fluid accumulation around the pericardium. So if this is your heart has a covering known as pericardium, right? There should not be any fluid in this layer. So there is 2 layers of pericardium. Okay. So inner and outer layer. In between this layer, if there is collection of fluid, that is what we call pericardial effusion. It can be due to a lot of causes, like just like pleural effusion, it could be transudative, it can be exudative. And patients with congestive cardiac failure can develop pericardial effusion. Okay. Patient with tuberculosis, neoplasm can develop it also. Some patient can also develop if they're having aortic dissection or aortic aneurysm. And sometimes pericardial injury, like someone got a stabbing wound in the chest, that can also cause a pericardial effusion. There comes your next important one. Sometimes fluid can get accumulated in an excessive way in the pericardium that it start compressing the heart. And if it start compressing the heart cannot get relaxed properly, okay, and that it can cause heart failure. And that is what we call cardiac tamponade. Okay, in these sort of cases, if you suspect pericardial effusion, you can just do a bedside echocardiogram, and that will confirm your diagnosis. Okay, and if you do a bedside echocardiogram, you confirm that it's pericardial effusion. Treatment can be just aspiration of the fluid and treatment of the underlying causes. But if it's a cardiac tamponade, okay, it's a life-threatening condition because your heart is getting compressed, and because heart is getting compressed, it's eventually getting into failure, and patient develops feature of heart failure, dyspnea, orthopnea. Okay, patient gets distended neck vein, which is a raised JVP, and eventually this patient develops shock. You can also get pulsus paradoxus in these patients. There is a triad of cardiac tamponade, which you should remember: low blood pressure or hypertension, raised JVP, and decreased or muffled, excuse me, decreased or muffled heart sound. So anytime in the exam they say muffled heart sound, you should consider either it's pericardial effusion or it's a cardiac tamponade. Cardiac tamponade, you only say that if you get hypertension and raised JVP associated with the muffled heart sound. So you have to do a echocardiography to confirm the diagnosis, and treatment should be urgent insertion of the needle, which we call pericardiocentesis. Any question, guys, so far? The next one and the last one in the pericarditis is constrictive pericarditis. Constrictive pericarditis is the diffuse thickening of the pericardium. So in here, not the myocardium. When myocardium get thick and rigid, we call it restrictive cardiomyopathy. When pericardium get thick, that's constrictive pericarditis. Usually it occurs in response to some inflammation, sometimes even after viral infection, thoracic radiation, open heart surgery, it can happen. The problem is when pericardium get thick, sometimes it results in reduced distensibility of the cardiac chamber, because heart is enclosed in pericardium, right? To get it relaxed, pericardium needs to be relaxed also. If your outside is rigid, inside cannot balloon up, right? Or inside cannot get distended. So what will happen eventually? This patient again develop abnormal diastolic feeling and eventually diastolic heart failure. So symptoms will be same in here also. If you do an X-ray chest in this patient, you can get a very distinctive feature, which we call egg on shell. Like this is your egg, the heart is the egg, and see the shell in here. This is the calcification of the pericardium that you can see. Okay, so that's your constrictive pericarditis X-ray. Any question, guys? I know this is a lot to take in one class, but tonight we are going to finish cardiology. So we have hypertension left, and then we can finish. So you guys have any questions so far in valvular heart disease? Good. Next, move on. So hypertension is in your chapter 86 in the JM. So we'll follow JM for this one. So all of you know what is hypertension and what is the normal blood pressure. Optimal blood pressure is less than 120/80. Normal, you can say, up to 140/90 is normal. Or like if you say is exactly, that should be 139/89, that's normal. When it becomes above than this, it's hypertension. So we divide hypertension into mild, moderate, and severe. Very good question, Dr. Islam. So usually uremic pericarditis, colchicine is the best one. Okay, but you can add it in other pericarditis also if NSAID doesn't help then. But for uremic pericarditis, colchicine works really good. So grade 1 hypertension, it's 140 to 159 systolic, 90 to 99 diastolic, moderate 160 to 179, 100 to 109. You need to remember these things, okay, unfortunately. Severe is more than 180, more than 110 diastolic. Sometimes it could be only isolated systolic hypertension. That means diastolic is good, but systolic is higher. There is a guideline that for any adult more than equal 18 years of age, you should do hypertension or blood pressure screening, okay, at least every 2 yearly. What are the causes of hypertension? Almost 90 to 95% is essential hypertension. That means no underlying reason. But we need to remember that 5 to 10% cause of hypertension, because if you can treat them, then patient hypertension will be treated. So that's why it's important. So among these 5 to 10%, kidney is the most likely cause. So it could be glomerular nephritis. Very important is renal artery stenosis. Some of the endocrine causes like primary aldosteronism or Conn syndrome, Cushing syndrome, pheochromocytoma can cause it. Coarctation of aorta can cause it. Oral contraceptive like OCP can cause it. Very important to remember. Steroid can cause it. NSAID can cause it. Sometimes pregnancy can cause hypertension also. Very important is this table. Sometimes they give a little clue and you need to understand that what they're talking about. Like for renal artery stenosis, usually you get a renal bruit in the abdomen. For glomerular nephritis, the feature will be with hypertension, patient will have hematuria, proteinuria, okay? All the features of nephritis will be there. If it's a polycystic kidney disease causing hypertension, you will get bilateral kidney mass, sometimes with or without hematuria. In coarctation of aorta, you will get a delayed femoral pulse. That means radiofemoral delay will be there. Primary aldosteronism, nothing much. Sometimes OSA or obstructive sleep apnea can get complicated by hypertension. Okay, so in that time you can get snoring and daytime sleepiness. Some of the drug, some stimulant, soft drink, energy drink can also increase high blood pressure. OCP can cause it also. If it's a pheochromocytoma, patient can present to you with a paroxysmal or episodic hypertension with headache, sweating, and palpitation. So this physical examination finding are important. Okay, so if you get epigastric bruit, you think about kidney artery stenosis. If you get palpable abdominal mass in the flank, you think about polycystic kidneys. If you get a delayed or absent femoral pulse, you think about coarctation of aorta. If you get moon phase with truncal obesity, with abdominal stria, okay, you think about Cushing syndrome. So these are all important. Now come to two other terms of hypertension. One is called malignant hypertension and another is refractory hypertension. Refractory hypertension is that someone having blood pressure more than 140/90, despite giving maximum 2 drugs for 3 to 4 months. So if you try maximum 2 drugs for 3 to 4 months, still blood pressure is higher, that's refractory hypertension. Malignant hypertension is someone's having a diastolic pressure more than 120. With that, if someone develops end organ damage like retinopathy, nephropathy, that becomes malignant hypertension. Come to renal artery stenosis. Renal artery stenosis is very commonly causes hypertension. There are mainly two important causes. One is atherosclerosis. So sometimes renal artery can have atherosclerotic plaque and develop stenosis. That's the majority of cases. But young female, sometimes they can have a condition called fibromuscular dysplasia, and that can lead to renal artery stenosis. So young female having renal bruit, you can think about fibromuscular dysplasia rather than atherosclerotic kidney artery stenosis. How you diagnose this patient? You do a Doppler ultrasound. And when you do Doppler, you can find out the stenosis. Very important question that someone having renal artery stenosis, single kidney renal artery stenosis, let's say only right-sided kidney is having renal artery stenosis, and patient having hypertension. What is your first line antihypertensive? For someone who is having only single renal artery stenosis, the first line is ACE inhibitor. But if someone develops bilateral renal artery stenosis, you should not use ACE inhibitor. For them, we can use calcium channel blocker as our first drug. Hypertension, how we detect hypertension? So obviously, you know, we use the sphygmomanometer. Now, diagnosis should not be made only on the basis of a single visit. That means you get hypertension in one visit, you say that you are hypertensive. It's not like that. So you should at least do another blood pressure reading within the next 3 months. And again, within the next 3 months, if still it is high, then you can say it's a hypertension. As we already told that this is the recommendation of blood pressure. So all people aged more than 18 years, every 2 yearly, we should measure blood pressure. This is one of the screening tests. Now come to the follow-up and when we can start medication. Not every patient come to you with hypertension, you will just start giving them medications. Lifestyle modification plays a very important role in here. So you don't just give medication for someone who is having 140/90 blood pressure. In many countries they do that, okay, but not in Australia. You try healthy lifestyle modification first. But when? So let's say someone is having optimal blood pressure, then you don't need to do anything. You just follow the normal screening again in 2 years' time. Someone having 120 to 139, 80 to 89, you can recheck in 1 year time. Now, if it's grade 1 hypertension, then you should confirm it within the next 2 months. In the meantime, patient will follow lifestyle modification. If it's grade 2 or moderate hypertension, you should evaluate or measure the blood pressure within the next 1 month time. In the meantime, lifestyle modification. If you want, you can also refer this patient to the hospital, that's fine. Any patient more than 180, 110, that patient is high risk. So you should evaluate the patient at least within 1 week, or you can start medication also. Anything is fine. So if mild hypertension is found, you can do another observation in the next 3 months. But you should make sure patient start lifestyle modification. Any patients whose diastolic blood pressure is more than equal 115, or they are having target organ damage. Like someone's blood pressure is 140/90, but they already developed retinal problem, like hypertensive retinopathy. That patient needs immediate treatment. You can't wait for just lifestyle modification that time. Or someone's develops diastolic blood pressure more than 115, particularly they are also having target organ damage, especially retinopathy, nephropathy. You should start immediate drug therapy for them. So these are the population who needs urgent medical treatment. But most of the other, you just do lifestyle modification first. What is ambulatory 24-hour blood pressure monitoring? Ambulatory means patient will do his own work, okay? And in 24 hours time, this machine will measure patient's blood pressure. Sometimes what can happen that you measure blood pressure in your office, it's very high. And then you ask your patient to measure it at home. And in home, it's totally fine. It's normal. So what's happening? We should think about white coat hypertension. So when there is a marked discrepancy between office BP and home BP, then you do this ambulatory 24-hour blood pressure monitoring. This is not Holter monitoring, guys. Holter looks into the rhythm, not the blood pressure mainly. Okay, so this is a little bit different thing. And these are the guidelines of ambulatory blood pressure measurement. So if you get very unusual variation of blood pressure in the office BP, discrepancy between office and home BP, patient having sleep apnea, okay, resistant to drug treatment, in these cases, you can do ambulatory blood pressure measurement. So now come to the management again. So management, if patient's average diastolic blood pressure is 90 to 100, there is no evidence of end organ damage, then a non-pharmacological therapy is indicated for 3 months' time without any antihypertensive. If patient is on any kind of medication which can increase blood pressure, like NSAID, steroid, OCP, hormone replacement therapy, you should stop it. What are the behavioral intervention or non-pharmacological approach? The most important one is reduction of body weight. If you can reduce 1 kilo body weight, your blood pressure will drop by 2.5 millimeters systolic and 1.5 millimeter diastolic. So it's very important. That's the first thing that you do. And other than that, obviously reduction of excess alcohol intake, reduction of sodium intake, so salt intake should be reduced. Then exercise, reduction of stress, smoking. So remember, smoking causes acute rise in blood pressure, but it doesn't appear to cause sustained hypertension. Management of sleep apnea. So these are the things. Mainly patient needs healthy balanced diet, exercise, making sure their body weight is maintained. That's the first thing that they need to do. So you got a patient with systolic blood pressure more than 140, diastolic more than 90 on several occasions. You confirm hypertension, start lifestyle modification. During this lifestyle modification, we also measure this 5-yearly absolute cardiovascular risk. Remember that chart that we have done? So someone has hypertension, and now you did a 5-yearly cardiovascular risk assessment. If it is low risk, then you can just try lifestyle modification for 6 to 12 months. Okay? If blood pressure remains elevated even after 6 months of lifestyle modification, then you can start medication. If cardiovascular risk assessment is moderate, you can again do a lifestyle change or lifestyle modification for 3 to 6 months. If that doesn't help, then start medication. If it is high risk, more than 15%, having associated target organ damage, okay, for them, you can begin drug treatment immediately. Okay, so it's a very important thing is to measure this 5-yearly cardiovascular risk assessment. So what are the medication that we use to treat hypertension? The best would be ACE inhibitor or ARB, especially if patient is more than 55. You can use any of these medications, so ACE inhibitor, calcium channel blocker, or hazard diuretics. So we have A, C, D. ACE inhibitor, calcium channel blocker, and diuretics. Diuretics are usually used for more elderly patients like above 65 years. If target not reached after 3 months by using a monotherapy, you can use any of it, but after 3 months, still patient is not getting target value of high blood pressure, then you combine medication. So you can combine ACE inhibitor with calcium channel blocker. You can combine ACE inhibitor with thiazides. You can combine ACE inhibitor with beta blocker also. But that's not usually the commonly we use. Commonly we use these two. So you can use ACE, calcium channel, ACE diuretics. If still after combining these two drugs, patient's blood pressure is not well controlled, after 3 months, you can use all the three. So ACE, calcium channel, and diuretics, all the three you can use. Still not helping, you can start using a spironolactone, or you can seek specialist advice. Okay, so that's your ABCD that you usually use for hypertension. So A is ACE inhibitor, D diuretic, beta blocker, and calcium channel blocker. Beta blocker is not the primary medication for hypertension, remember it. Okay, and you should never ever give beta blocker and calcium channel blocker at the same time, because both of them will reduce heart rate. So these are the ineffective combination. So do not give beta blocker and ACE inhibitor, diuretic and calcium channel. We can give it, but it's not very effective. But you should never ever give beta blocker and a rate limiting calcium channel blocker. Or do not give spironolactone and ACE inhibitor, because ACE inhibitor causes hyperkalemia, spironolactone causes hyperkalemia, and this patient can develop massive hyperkalemia and can die of cardiac arrhythmia. Okay, and because ACE inhibitor and ARB both are same kind of drug, we don't give both in the same patient. We have hypertensive emergency. So when a patient develops hypertensive emergency, they can develop features of end organ damage. So there will be very high blood pressure with patient can develop hypertensive encephalopathy like headache, confusion. Patient can develop heart failure features. Okay, so most of the patient's blood pressure will be very high, but the thing is you need to gradually reduce the blood pressure, because if you suddenly just drop the blood pressure, it can precipitate a stroke. So aim to reduce the blood pressure by no more than 25% within the first 2 hours. For these patients, better approach will be starting a calcium channel blocker with an ACE inhibitor. Now, the most important chart from whatever we discussed from hypertension is this one. So lots of things we need to consider when we give a medication, especially in and antihypertensive medication. So patient's medical condition is important to know. So let's say someone who is having asthma and COPD, and that patient you want to give antihypertensive. You should not give beta blocker because it can cause bronchospasm. But you can give all other medications like ACE, diuretic, or calcium channel blocker. Calcium channel blocker can cause constipation, same with thiazide diuretics. So for someone who is having bowel problem or constipation, best will be ACE inhibitor. Someone who is having bradycardia, you should not give calcium channel blocker because it can reduce the heart rate more. Same with a heart block patient, don't give beta blocker, don't give rate limiting calcium channel blocker. Cardiac failure, best one would be ACE inhibitor or diuretic. Calcium channel blocker, usually we don't give unless it's diastolic heart failure. Diabetes, thiazide diuretics, we don't give in a diabetic patient because it can cause glucose intolerance. But very good is ACE inhibitor in diabetic patient. Same with dyslipidemia, you don't give thiazides. Same with hyperuricemia, you don't give thiazides. Peripheral vascular disease, best would be calcium channel blocker because it can cause vasodilation. But you should never ever give beta blocker in a peripheral vascular disease patient. Pregnancy, we don't give ACE inhibitor, we don't give diuretics, but you can give calcium channel blocker like labetalol or methyl-dopa. Renal artery stenosis, if it's single renal artery stenosis, ACE inhibitor can be given. If bilateral renal artery stenosis, then best would be calcium channel blocker. Clear, guys? Any question? So this chart is there in your GEM table 86.9. You guys to remember the chart very like in very detailed way. Just memorize. Now you also know the cause. So please try to remember it. A lot of questions come from here. And that brings us to the finishing of cardiology. There is palpitation that will be covered in ECG class. You can give nifedipine in PVD. So ECG class is not a part of our 2 weeks free session. It will be only for our course students. So most likely it will be after these 2 weeks free sessions. Now, for someone who is looking for, let's say, screening test, there is a RACGP Red Book, the 9th edition. All the screening, you will be able to get it here. So go through this one because the screening comes frequently in exam. So you just go through the chapter by chapter in here. So the important screening test for your exam will be, let's see. Type 2 diabetes is important. Then prostate cancer, not very important, but colon cancer, breast cancer is super important. You should also look into skin cancer. Cervical cancer is very important, and ovarian cancer, not very important, but just go through it. So these cancers you just need to go through, but colon cancer and breast cancer is like very important. Now, if we go to the blood pressure, let's have a look. See, blood pressure should be measured in all adults from 18 years of age, at least every 2 years. BP should be interpreted in the context of an absolute CVD risk assessment after 45 years of age. That means CVD risk assessment, we should start from 45 years of age. But for Aboriginal, we start from 35 years of age. So all adults from 18 years of age will get blood pressure measurement. That will also include Aboriginals. And there are also in here, see according to the cardiovascular risk assessment, how often you will measure the blood pressure, that's also given in here. So please go through these things, it's very important. Okay. So when both renal artery stenosis, CCB, calcium channel blocker, is appropriate. So that's pretty much everything about our cardiology session. We will do a cardiology question solvation in the next class, and you will get to see that how we can use our theory knowledge for solving questions. Okay, and once we finish that, then you can go through the Q bank, which will be given for the course students. And in the software, there are also one of the mock exam is there. You can go through that mock exam once you understand that you are all good with cardiology. So let's finish it here tonight. Do you guys have any question? Are you guys enjoying the sessions? That's very good to know. Right. Make sure you, like, if you are just started your preparation, I would say that this initial few weeks, you will feel confused. And that's pretty normal to feel like that. Okay. Eventually, after 3-4 weeks, you will get adapted and you will understand the pattern. You will understand what you need to read and what you don't need to read. Okay. And how you should prepare. So eventually you will understand that. So don't get stressed about it. Start reading your AMC handbook, the MCQs, that's important. And together you will also finish the cardiology that we have been doing. Okay, do not fall back, because if you fall back, you will never ever be able to cope up with the stress of reading a lot of topics. So try to cope up with the situations, try to finish what we are finishing. And the most important, try to get some study buddies, like at least 2-3 study partners should be there. Someone's screen has got shared, unfortunately. Okay, so we'll go through this sort of things again and again, that what you need to do and what you don't need to do and how you will prepare. There will be a orientation class for the course student after this 2-week session. So in the orientation class, I will go through each and everything again with you, that how you should prepare, okay, and what are the things that you look for in the software and how to use that perfectly. So for these 2 weeks, just try to get adapt with me, and then we'll move through more and more depth. Okay. Thank you all. Have a good night then.